Good afternoon. I'm Sara Bleich, Professor of Public Health Policy at the Harvard T.H. Chan School of Public Health. Joining me today is Ashwin Vasan, Richard L. and Ronay A. Menschel Senior Leadership Fellow at the Harvard Chan School. Ashwin served as the Commissioner of New York City Department of Health and Mental Hygiene from 2021 to 2024, and he's an alum of the Harvard Chan School. At this time of great uncertainty and volatility in federal public health policy, we'll be talking about how state and local governments can drive public health forward. Welcome, Ashwin.
It's great to be here. Thank you.
Great to have you.
Yeah.
And to begin, what do you see as the perils and opportunities of this moment?
Yeah, I use the word opportunity very cautiously because I want to start by acknowledging that this is a really challenging time for all of us who care about health, who care about public health. The uncertainty, the chaos that's kind of emerging in the way in which the new administration has arrived, the cuts to public health agencies, the relitigation of settled science, that's all really destabilizing. And my worry is that it's going to cause real and immediate harm to so many people, but particularly the vulnerable, which has been sort of the thrust of my career. That said, I do think that those of us who care about public health and care about health in general need to be seizing this moment to be filling the vacuum with even better ideas, not looking backward, but looking forward at what we need to be doing to reconstruct public health systems and health systems that are actually working for people. Because the truth is, it's for a lot of people, our health, the way that we've oriented and organized our health systems isn't working. Whether you look at the measures of falling lifespans, widening health disparities and inequities, the cost of accessing health care, satisfaction with our healthcare system is at all-time low based on a Pew survey that's about 20, 30 years old, historic lows. On every metric, we're not delivering for people, and particularly for working people. And so we have to look in the mirror and say, what are we going to do to build back a better future for health and to be creative in doing so? So that's where I see the tension, and it's not an easy tension to navigate because you want to mitigate harm in the near term for sure.
So now I'd like to take a closer look at some of the specific programs and policies under threat, starting with Medicaid. Yeah. Earlier this month, House Republicans passed a budget resolution, and it signaled significant cuts to Medicaid. We have yet to see if these cuts are going to be materialized and included in the budget. But what would this mean for states, and how would you see them responding if it actually happens?
The scale of the cuts being proposed are tremendous. I can't even call them cuts. They're essentially a wholesale gutting of an essential safety net health program, Medicaid, that covers tens of millions of Americans, almost 100 million Americans at its peak. And my fantastic students, some of them are here, just did a great presentation for me right before this session around the unwinding of Medicaid after the pandemic protections expired and what that might teach us about the impacts for this kind of congressional approved cut. And there is no future with this kind of scale of cuts that doesn't result in tens of millions of people losing their health care, and that those costs getting shifted to acute care, to hospitals, to uncompensated care at great cost to the health and well-being of vulnerable people. And so I'm glad to see that there is some emerging pushback, even from Republican senators and Republican legislators saying that they have no intention of approving these scale of cuts. I'm also worried about the kind of push for work requirements that are just time and again not proven to work. 92% of Medicaid recipients below the age of 65 not on disability are already working. So what is it that's being intended other than to pull coverage away? Again, taking the other side, what is it that we can do to improve Medicaid? Satisfaction with Medicaid is actually fairly high, but the counterfactual is having no health coverage at all. But when we put up Medicaid against Medicare or commercial plans, Medicaid falls down, providers don't get paid enough, and we struggle to pay for the things within Medicaid that actually make the biggest difference in health. We in New York and states like North Carolina have done a fantastic job with Medicaid waivers and expanding the basket of services that can be paid for with Medicaid dollars. But why does it take so much effort to do basic things with the core safety net program? I mean, we got several billion amongst, 50% of the Medicaid recipients living in New York City. We got just a few billion to pilot test approaches to use Medicaid dollars to pay for social services. Why isn't that standard practice within Medicaid, given how important we know these services are and these needs are? So can we use this as an opportunity to think creatively to get health-related social needs, social determinants of health funded through a core public health and healthcare program like Medicaid?
Can you say a word about the waivers that you did in New York City?
Yeah, so we spent the better part of 3-4 years working on an 1115 waiver, which gives us flexibilities to spend Medicaid dollars in new ways. It's not the first waiver that New York State has had, but I worked closely with my state colleagues to get the latest waiver passed last summer, which really was fairly modest. It's about half of what we asked for in 3 years' time, essentially to prove that even amidst a very powerful healthcare industry in New York and a powerful hospital system in New York, that we could get dollars, Medicaid dollars, into the hands of social service providers that make a huge difference in communities. I'm glad we got that passed, but it took extraordinary amounts of effort to get just a fraction of the overall budget approved to use in this more flexible way. We need to figure out ways to more quickly mainstream what we know works. And we know that 80% of health is formed outside of the healthcare system. So let's get those dollars into those services in that 80% quicker and more methodically.
And that's a perfect transition to the next question, which is opportunities to invest in prevention. And I'd love to understand how you see this as an opportunity for state and local governments to redirect the conversation away from acute care and towards prevention.
Yeah, I think Medicaid is one example, but not the only one. I think public health budgets need to be revisited and reinvested in. New York City has a budget of over $100 billion, and our public health agency, which is widely regarded as one of the strongest and the best funded, only receives about $2 billion. Almost half of which is comes from non-city sources. So that's a fairly modest 1% of the city's budget that's going to public health for core things like disease surveillance, maternal health, overdose prevention, mental health services, you name it, chronic disease prevention. Should we be and can we be investing more given the return on investment that public health delivers for people and communities and for families, particularly working families? I think the answer is yes, and I think we're going to need state and local leadership to really think carefully about what are we paying for. In doing so, we can recruit the next generation of talent. We need extraordinary investments in our data infrastructure. In my time, we established a Center for Population Health Data Science using city dollars and trying to recruit the best talent from tech to come and work on data science in the public sector. We need much more of that. We need a modern data system, which currently public health systems are fairly anachronistic and retrograde. We need to support our workforce. I walked into a health department with a 30% vacancy rate.
30%?
Yes, and
Wow.
some of those were federal lines that went away, but a lot of them were not. And we had to really invest in worksite wellness, worksite mental health, better benefits, better access to care, and pay equity to really start to get at the root of why are people fleeing the public health. While applications to schools of public health are at all-time highs, why are people fleeing government public health? The trauma of the pandemic is a big explanation, but there's underlying causes that leaders need to address. So states and localities are going to have to take a huge leadership role, particularly in the face of what can only be described as a bit of an abdication by the federal government and the current administration.
So you alluded a bit to innovation and technology. and would like to hear from you how state and local governments can be on the leading edge when it comes to technology. You mentioned a little bit about the work in New York, but what can others be doing as they think about this?
I think we need to think about more modern ways and more routine ways to do disease surveillance. And I don't just mean infectious disease surveillance and mandated reportable conditions, but to think creatively about how we measure and forecast chronic diseases, how we unpack and how granularly we unpack inequities in our data at the block and the zip code level, how we merge myriad healthcare data with routine public health data, and then even better, how we start to get social services data, and how we take down or try to remove unnecessary barriers in our regulatory architecture that prevents us from doing so. We've been having these conversations for many years, and at some point, generative AI is going to pass us by unless we're able to sort of break down some of those barriers that prevent us from building modern informatics and technology in public health departments and public health systems. The question of privacy is a real one. We have to continue to protect health data, but most of what we need to do at a planning level doesn't require identifiers, and we just need to be able to move more quickly at a citywide or locality level or a state level to do public health planning faster and better using modern informatics. We partnered with Microsoft to build our data science center. It's going to require a much more expansive set of partnerships with tech to do so. One of the reasons we partnered with Microsoft was that they were interested in building capacity internally, whereas a lot of other partners said, we'll drop in technology and then you'll be dependent on it. So we want to build those skills up natively in public health departments and public health systems, but in the beginning we're just going to need to really lean on smart partnerships with the tech industry.
Yeah. So let's switch gears again and talk about reproductive rights, which are increasingly being stripped away. What can state and local governments do to protect their residents' rights when it comes to reproductive health?
I'm very proud of my record and our record on this issue. I was just a few months into my tenure when the Dobbs decision was leaked. I think it was March or April of 2022.
Right. Yep.
And then the decision came through in June. And one of my proudest days was standing on the steps of City Hall with all of the women leaders, from agency heads to deputy mayors, speaking openly about their own stories of accessing reproductive health care and abortion care and ensuring, and it being determinative in them being where they are today. Mostly women of color in our administration. And so very proud of that work. We responded in kind by building the first in the country abortion access hub, a nationwide call line where anyone could call New York City government and get access to an abortion or reproductive health care in our city. Over 2,000 women availed themselves of that in the first year. And we advertised in places like Georgia and Texas and Florida and Arizona to do so. So many of them are coming from those restrictive states. We became the first place in the country to do medication abortion, free medication abortion at our public health clinics, to do telehealth medication abortions. We instituted new data privacy rules to enhance shield laws to ensure that interstate prosecutions we could reduce the risk of that for women coming to New York City. It's a sad state of affairs when that's the patchwork system that we have, where people have to come to New York City to access this basic human right. So it fills me with no shortage of regret that that's the case, but I'm glad we certainly stepped up with resources, and in the main, those were all city resources, right? Those resources didn't come from the federal government or anywhere else. We had to pay for that ourselves, and so it represents just another example of where cities and localities and states have to step up and solve their own problems in the absence of federal leadership on these issues.
And what about in areas of the country where the public health budgets are just tiny, much smaller than New York City?
Yeah, I think there is a real conversation to be had about the structure of our public health system and whether or not we can really maintain and sustain an entirely fragmented and balkanized local system that we have, where you have such vast disparities in capacity and funding. The stories are quite well known about the CDC receiving faxes and Excel spreadsheets, and a lot of those are coming from low-resourced county and other health departments. And so if we had federal leadership on this issue, we could think carefully about how we support those localities. The CDC did put out public health infrastructure dollars for the first time during the last administration, and so we got some of that, but really we were focused on that getting out of New York City and into places that need it even more. But I don't know that that's continuing.
Yeah.
And so I think state leaders, governors, and state health departments need to think carefully about how they support and partner with their localities and which capacities they take on. Mm-hmm. Maybe we need to be in some ways scaling down in certain areas in local health, like county and local health departments, and expanding at the state level in order to make up those differences. Very different, very complicated, particularly from a governance perspective and a funding perspective. But we do need to be rethinking this, because I don't think, to your point, I don't know. Last thing I'd want to do as we're reshaping technology or reshaping investment into state and local public health is to leave all these county departments behind.
Right.
They need to be at the table working with us. So it's going to demand a bit of creativity.
And this brings us to the topic of communications. So the new administration is placing restrictions on external communications from federal health agencies. Facing this potential information gap, as well as the threat of misinformation, what can state and local governments do to fill the void, and how can local leaders become better communicators about important public health topics?
Yeah, building trust, I think, comes from presence, consistency, and authenticity, and a willingness to really communicate what you know today, what you don't know, and what might change in the future, and reserve the right to update your priors and re-communicate again. As in my time as health commissioner, I was always humbled by how important small things I did in public communications really mattered to people. Mm-hmm. Whether it's a commercial here or a speech there or a community event somewhere else, it makes a big difference. So, number one, I think officials need to be out there, and out there much more, and public health communications, like any other core part of public health infrastructure, needs to be invested in. And one of the first things I did was to actually get a communications firm, not a public health communications firm or a health communications firm, but a general communications firm that works with candidates and institutions and private sector, public sector, and came into our shop and really looked at our comms apparatus and how we do things, and has reshaped it, and we made new investments into it. So it has to be treated as a part of the core operating model. It's so important, particularly in this hyper-atomized, digitized world in which we consume information. We can't be playing in an analog way, which in the main we currently are. Right. Number two, I think it is about authenticity and how you show up. Expertise is important, but humanity is even more important, especially at this time when we need to bridge divides and find, as one of my students said, a nidus of partnership, or a nidus of commonality with people. We have to get better in public health at really understanding where people are starting from and hearing them, even if it might be the least evidence-based or least scientifically sound position. Our ability to engage with people who hold those beliefs, hold those views, is a skill, and it's a skill that we need to be training our new leaders to invest in, but existing folks really need to take the time and work on those skills. And then, the last thing is, I think, language and cultural competency remains really important. I think about mental health in particular. The models we use and the language we use around mental health isn't understandable to a lot of people. It's hyper-medicalized, it is, conditions like depression and anxiety don't exist in many cultures in that same way, right? And we aren't particularly adaptable. So in a place like New York City, one of the most diverse city one of the most diverse cities in the world, let alone the country, that's table stakes. Everything gets translated into 30 languages. Every commercial gets translated into core set of languages. We have to be doing that everywhere, particularly with the shifting demographics of this country. We have to be communicating however we can, wherever we can, and particularly in the languages that we can to meet people.
So let's switch gears and talk about you. And would love for you to give us a sense of your career path, the choices that led you here. What were some of the major forks in the road for you? And what have been some of the biggest surprises or lessons learned?
That's a big question.
It's a big question.
Let me just say my path has been interesting and I wouldn't say circuitous, but certainly not conventional in some ways and conventional in others. I didn't go through the CDC EIS program and kind of go from different leadership positions in government public health. And in a way, I think that that's somewhat of an advantage. I started as an economics concentrator, really thinking expansively about the role of markets and international development at a time when that was how we did big things, particularly in the developing world. My focus was almost entirely global at the time. And we're talking about the midst of the HIV pandemic, the last great pandemic, and that being the kind of salient public health issue of our time. I came from a family of doctors that inspired me, but I honestly had a lot of insecurity about living up to their especially my mother, her example. Mm-hmm. Public health represented for me an amazing convergence of health and medicine and the study of large-scale social, economic, and cultural forces and how they can converge on the lives of people and communities and entire states and populations. And so I dove in as soon as I could and embraced the challenge that was before us, which was HIV. Mm-hmm. I tell my students the same thing, which is I really do ascribe to this Japanese notion of ikigai, right? The finding out what you're good at, finding out what you're passionate about, and finding out what the world needs. And I was always paying attention to what the world needs and really externally attuned to the challenges of the day and wanting to be a part of those big challenges. And so throughout my career, I've tried to take steps that realize that vision of ikigai, and that's led me to some interesting choices, whether leading a mental health organization or then being asked to serve as health commissioner in the midst of the COVID pandemic. These are things that really align one's passions and interests and skills with what the world needs. And that I think that's embodied in public health. We always try to address the pressing issues of the day through our tools and through prevention. And so that's really informed how I do things. Obviously, a massive influence from this place. I arrived here when I was 21 and bright-eyed and bushy-tailed and green, and met Paul Farmer very early on, someone who really also helped me marry the bedside with the boardroom and the places of influence, and kept me honest about my motivations, about why I was doing each thing. Folks like Jim Kim, who took me under his wing to WHO and other places to see how do you institutionalize the moral imperative in these complex bureaucracies, skills that I used with me as commissioner and continue to use today and will in the future. So, my path, I think, is a very human one, one that, and I'm proud to say that to my students, I didn't pick a problem and then stick with it the rest of my life. I picked an approach and a set of issues in health and public health that I'm passionate about, and I found my way through that. And I think most of us in public health feel similarly. When COVID hit, none of us were COVID experts, maybe a few of us, but not too many. But we all did it. We all jumped in because that was what the world needed. And the only thing that might be true coming up is change and more change, and so hopefully I'll be there and with all of you to sort of tackle those issues.
And what surprised you?
What surprised me about my career?
Just along the path.
You know, it's always surprising to meet support and care and allies in the strangest places.
Yeah.
And the most in some of the most unexpected ways. And so, you know, I try to teach my students and anyone else to stay open to that. You know, I'm thinking a lot about the second mountain of life. You know, the first mountain of life being where you create your career, you create your identity, you ascend the mountain. And then the second phase of life is very much about finding peace within the work that you do and your impact in the world. And I'm just so lucky to have picked a career like public health where I don't have to make that distinction. I get to work every day on things that give me great meaning, I hope are making a difference in people's lives, and are quite authentically human to me and quite authentically aligned with who I am as a person.
So I've got one more question for
Yeah.
you. You've mentioned students a number of times, and many of the folks in the audience today are students or potential students thinking about making careers in public health. And so what advice do you have for those at the beginning of their careers, or who are thinking about joining the field at such a challenging moment?
Yeah, and I think that's I often think back to the start of my public health career, and while we faced big challenges, there was big cooperation. You know, we were taking on HIV as a globe. We had things like PEPFAR and the Global Fund and cooperative agreements to, even if we had disagreements, we were putting our engine of change behind this notion that together we can solve big problems and the big problems of the day. I feel a lot of empathy for the students today because that consensus is being attacked all across this world. The idea that we can actually solve things together. So the first thing I would say to them is don't give up on that. You have to hold the flame for that. The only truth in this world is that there's no bigger project than the human project. And we're all a part of that project. And so don't fall into the traps of insularism and sort of certainly nationalism and thinking narrowly about your interests and what's in front of you. Continue to think expansively and cooperatively and collaboratively about where you can find partners. The second thing I would say is that also means being open to views that are not your own. And I think in public health, we haven't always been good at that. We have a lot of learning to do about how to be open. And even if we have fundamental scientific, moral, values, strategic differences with people, inviting them into conversation, calling people in instead of calling people out, and shutting down conversation. This is the only way things get done, is if we can find that opportunities to form bridges with people who are not like you and who don't share your views. When you're a health commissioner for a city of 8 million people, everyone is your patient. And that means, you know, all the way from communities in Staten Island who have a very different experience to brand new arrivals coming on, being shipped in from Texas in the most heinous ways. Like, these are, they're all your concern, and you have to find ways to bridge divides. And the only way to do that is by starting with humanity and starting with what we share, and not letting things like identity and other things divide us to such a degree that we can't get things done. The last thing I'll say is to the new generation is be learning all the time. Not only are we facing these political wins and social wins, we're also facing a technological revolution happening concurrently. And this is a huge opportunity for public health to be at the front of that change, not on the back foot. But that means we have to really learn, really get smart and embrace. I spend most of my free time reading on politics and tech. Those are and tariffs more recently. But we have to get smart on opportunities to make public health at the modern edge of technology, not at the receiving end of. I don't have all the answers on how to do that, but it will require an openness to learning and really staying ahead of the curve of what changes are coming in technology.
Ashwin Vasan, thank you.
My pleasure. Thank you.
And thank you all so much for being here today. If you missed any part of the discussion or if you want to rewatch it, a recording will be posted on the Harvard T.H. Chan School YouTube page. Have a great afternoon.